bit. I'm a lawyer by trade, and so I'm used to standing up and talking in front of juries. I feel more comfortable doing it, so I'm going to talk to you the same way I would talk to a jury. I think it's important that you understand I'm a candidate for governor. I'm not a doctor. I'm not any expert on Medicaid or Medicare or health delivery systems at all. But as a lawyer, I work with, in the courtroom, what I can prove. I can become an expert on a specific area of the law when it is involved in a case, and I have to be ready to address that when I walk into the courtroom. I've done everything I can to learn about the Medicaid issue here in Idaho. Part of what I did was spend time with my father. He's a physician up in Coeur d'Alene. He used to be a VP in charge of medical affairs for the Kootenai Medical Center. And he tells me that there's one thing that everyone will agree on when it comes to healthcare and healthcare delivery in Idaho, and probably across the nation. And that is that the system is broken. People just simply don't have access to care, whether or not it's paid for by Medicaid or otherwise. We have people who are sick, covered by Medicaid. They try to get in to see a doctor, and they can't, and so they end up in the emergency room. Part of the problem is we have a shortage of primary care providers here in Idaho. Doctors don't stay. Doctors aren't happy, and the reason they're not happy is because of the work environment. They get sucked up into these mega companies like Salzer, and their focus there is how many patients can you see, and what can I do in order to bill insurance so I can get paid? And so you get people going into the doctor, if they're lucky enough to get in. I have a headache. Okay, here's a prescription for fill in the blank. Have a nice day. We've spent all of 30 seconds with the patient. But that's the healthcare delivery model that we have. And it's not working. So the question is, for me, looking at being your next governor, if you expand Medicaid, how is throwing more money at a broken system going to fix the problem? Okay, we're going to have another 100 and some thousand people coming into the system. Where are they going to go for care? It's going to be overwhelmed. The system is going to simply be overwhelmed. You can't take money and throw it at a broken model and expect a better result. What you're going to get is worse care. Maybe they had 30 seconds to spend with patients, now they're going to have 10. That isn't the way to fix healthcare in Idaho. Now, I've heard about an idea. It's not my idea, it's not an original idea with me, but it's working in Washington State, and I've been telling people about it as I've been traveling around. And that's the direct primary care model that Dr. Epperly say the committee discarded as not feasible here in Idaho. It's working in Washington, and let me tell you a little bit about it. Medicaid patients can be covered on it. The system or the person, if they can afford to pay, pays somewhere between $20 and $80 a month, depending on their age. And they get access to all of their primary ambulatory care, their basic health care. The doctors in the program work for a private enterprise. It's a for-profit company. Doctors are paid a good wage, and they're required to spend time with their patients. They're spending 20 to 30 minutes with each patient instead of 10 to 30 seconds with each patient. And they're talking about things that they didn't have a chance to talk about before, like preventative care. How to live healthier, how to adjust their diet, how to avoid coming back. The other thing that's unique is they have 24/7 access to doctors, patients do. In fact, while the doctor was here from Q Lions, is the company in Washington I'm talking about, they had a meeting down at the State House in Boise. I was there at the meeting where they explained this program. Right in the middle of the presentation, the doctor who was presenting got a call on his phone. It was one of his patients. He said, "Excuse me." He had to take a couple minutes to talk to his patient. The doctors in that treatment model are happy. They like their jobs because they're able to do what they got into medicine to do in the first place, which was take care of people, establish relationships with people. And it's working in Washington. Now, Dr. Epperly's talking about, well, what do you do when you have the catastrophic event? Well, the answer in Washington State has been affordable wraparound catastrophic care insurance coverage. Again, for Medicaid patients, it's covered by Medicaid. We have to change the model here in Idaho. People have to have access to quality care. They have to have access to primary care providers. You don't get there by just expanding Medicaid and throwing more money at a broken model. Because let me tell you what's going to happen. Right now with administration in Idaho, I'm told, and I looked at the data, it suggests that this is true, 40%, 40 cents on every dollar is taken up in administering Medicaid. That's a huge amount of waste. So you talk about more money coming in, but how much more is going to be wasted on a model that's broken? So I simply can't afford Medicaid. I can't endorse. I can't get excited about expanding Medicaid and bringing money into the state that's going to end up being wasted on a model that isn't working. And as far as Idaho not getting its fair share of tax dollars, you know, Idaho already gets back from the federal government more than it pays in federal taxes. How much more, as a people, do we think we're entitled to? Especially if we're not going to be responsible and fix the broken model first. And so that's my idea. If I get into the governor's office, I want to work with the legislature to put a model in place that makes sense. Because I believe it's possible, and so do other senators that I spoke to in the legislature, that we could take the money that we're already spending in Idaho, make a more efficient model, and use those same dollars to provide quality health care and affordable health care for everyone in Idaho with the money that we're spending now. And that would be my plan. I look forward to answering your questions. Thank you so much for your time.
So at this point, yeah, great. Get your questions on cards, and we'll get rolling. We have a good amount of time. Everyone's on schedule, so we should be able to get a lot of questions in. And what I'll do is, some of the ones we have are directed to a specific person, but I'll let everyone chime in as long as kind of time allows. To start, what did the Medicaid redesign work group think about direct primary care memberships? So we'll start with Epperly. Dr. Epperly, if you can answer that.
Yeah. First of all, just a couple things in terms of what was the makeup of the workforce. And I'll just stand when I do this because I recognize that people back there just can't see. The workforce was a good mix of both public and private folks from both the healthcare professions, representatives, consumers, the county associations throughout Idaho, the Idaho Hospital Association, Idaho Medical Association, the Idaho Academy of Family Physicians, employer groups. So it was a good mix of different people. In terms of the direct primary care question, we felt that that was a very viable option, but not scalable to the state of Idaho. So let me just put a point on that. In terms of having payments to primary care physicians for timely access and quality, totally agree with Mr. Bujak. That's a good thing to do. There are not any direct primary care practices in the state of Idaho at this point in time. If we're going to put 1.6 million people into a healthcare system, we've got to have some place for them to go. I agree that that model has potential and should be part of the redesign of how healthcare is done in the state of Idaho. But to say that this is going to be a model that tomorrow is going to be where these people to go, there are none. So it's very hard to put anybody into a system where there's no direct primary care practices at this point in time. Now, with that said, I want to mention one other point because it's very important for you to understand. The state of Idaho recognizes, and I agree with Mr. Bujak, that we've got a fractured system. And in fact, I've written a book on the fractured system. So I totally agree with him on this. Part of what Idaho is also doing is transforming the delivery side of our system. So several of you in the room have heard of the Idaho SHIP grant, State Healthcare Innovation Planning Grant. It was a $3 million grant we'd received from the federal government through the Centers for Medicare and Medicaid Services to redesign what the delivery side of the system should look like. We totally agree on the fact, more primary care, better integration and coordination of that care, better use of the subspecialists in hospitals and community services in those communities to design that. So when Mr. Bujak says that we don't want to take the Medicaid money and just cram it into a broken system, totally agree with that. But Idaho has worked hard for over a year and now has the implementation grant into the federal government to transform that delivery side. Because he's exactly right about the point that if we don't have accessible primary care practices for people to go to, then it's just a default to the emergency room where we're again spending more money. So the DPC, and I'll summarize with this, the direct primary care model that we believe is a viable model. It's right now at 0. It needs to be brought up to scalability in the state so that all people have access to a system like that. We must make sure, as he pointed out, that there are other payments, because the payment mechanism is only for primary care. So there must be other payments in a wraparound way for subspecialists or hospitalizations or catastrophic care, or it hasn't fixed anything in regards to the other parts of healthcare that happens. We do agree with the principle that we must start with the foundational element, which is quality primary care.